Our next panel will look at social determinants of health and developing a national standard for reporting. Over the last decade, healthcare providers, policymakers, and payers and vendors have become increasingly aware of the importance of collecting and acting upon social determinants. In response, many organizations have created a wave of new codes to address social determinants of health in their organization, but there is no public policy dictating a state or national standard for how clinical sites should capture those. As a result, there are numerous one-off solutions and wide variances at local, state, and national levels for how these codes are used and operationalized in pilots. Moderating today's panel is Andrew Ceresney, MiHIN Senior Community Engagement Director. Drew's primary focus at MiHIN is to understand community expectations for our hub and spoke information sharing model to ensure our stakeholders have positive experiences sharing health information. Our community engagement activities are specifically focused on understanding how individuals, community-based organizations, and care team members can work together to share social determinants of health. Coordinating the care coordinators is another example, an initiative to ensure more types of providers declare active care relationships in order to advance the quadruple aim focused on care, cost, quality, and provider well-being. Drew will be introducing our panelists. Please join me in welcoming them.
Good afternoon, everyone. I'm Drew Murray here at the Michigan Health Information Network. We'll ask our panelists to come on the stage now here and find your seat. I'm excited for this panel, one, because I think the readmission conversation we had before lunch set it up quite nicely. Trying to understand the value and understanding what's causing those readmissions. And I think one thing is trying to understand social determinants of health was one piece to that work, and understanding the codes that need to be available to track those issues that are behind those readmissions. So that's what we'll be talking about today. So I'll take a seat now and introduce our panelists. We have Cathy Commey from the Michigan Department of Health and Human Services. We heard a little bit about the state innovation model earlier. She'll share some information about that work. I think particularly given a lot of conversations around social determinants of health, a lot of excitement happens, but people are trying to figure out what is actually real, what is currently happening. SIM has a lot of things currently happening, so Cathy can share with that work. And then we'll go actually we'll start with then Alicia Meyer talking about the provider-delivered care management from the Michigan Institute for Care Management and Transformation perspective around how to continue some of the SIM work around collecting, aggregating social determinants of health information, and then closing out with Beth and Dr. Cathy Baase from the Michigan Health Improvement Alliance around their work with the Thrive Initiative and trying to understand the value of social determinants of health and bringing in more partners than just the traditional healthcare partners, business and larger community interests at stake. So I think first and foremost, I want to have this session make sure we understand what is currently happening around social determinants of health. So I think it's a good place to start with SIM, since there's a lot of activities in that current work, and then we'll go from there.
Thank you so much, Drew. Like Drew said, my name is Cathy Commey, and in my role at the department, I serve as the State Innovation Model Care Delivery Lead, which provides me the pleasure of working with over 340 primary care practices across our state and supporting them and engaging with communities in this state around social needs, and in particular with our community health innovation regions, which if you were here earlier, you heard Mary Ann Udow talk about our Livingston-Washtenaw Community Health Innovation Region. Within the state innovation model and the 5 communities and the 340 primary care practices, we've had the opportunity to use this demonstration to support the various actors in collecting individualized social need information or social determinants of health at the current point in time to both support point of care delivery as well as population program development. Our first focus was really on the process of integrating social needs screening in a systematic way within clinical practices and in community-based settings, and not necessarily in a standardized format, but in a way that was aligned across the various providers and communities in our state on specific domains, I'll call them. That's the term we use within SIM, and not necessarily around how a screening is administered, how the information from that screening is collected, saved, and then aggregated at a specific level to share. The time has gone on in this model where we've matured and have begun going down that road of how do you aggregate and share this information statewide to support that care coordination and population health program development. And we're working through that. Now that we've had alignment, now what do we do with the information that isn't specifically the same across every single program, provider's office, or community?
Thanks for that, Katie. Alicia, would you want to share some of the information from your organization, maybe learning from what we learned from SIM, and then how Michigan Institute for Care Management Transformation may push some of that work forward?
Sure, thank you.
It's turned on.
And now is it on?
Yeah, you're good.
All right. So thank you. Yeah, my name is Alicia Meyer, and I'm the Operations Director at the Michigan Institute for Care Management and Transformation, or MICMT. My other role is also with the University of Michigan Medical Group. I'm the Admin Director for Care Management for University of Michigan Medical Group. These two roles give me a great opportunity. So with the MICMT or Blue Cross side, we get to work very closely with the payer to develop a way to work with other physician organizations across the state to expand on the kind of work that Katie and MDHHS has done with SIM. And so the opportunity there is, how can we say, okay, SIM had 5 excellent regions that were able to pilot and develop processes for screening, which is not common across the state, and aggregating that data, which is also not common across the state. And so how do we take this excellent demonstration project and put additional incentives around it to make it more widespread and to understand what are the needs at a community level, not bounded by the 5 areas, but the entire state. And so we really appreciate all of the work that Katie and the MDHHS team have done and are trying to learn from what has happened there and then develop it further.
Perfect. Thanks, Alicia. Beth, would you want to share some of the information from your MiHIN organization around, obviously, hearing what SIM has been working on, understanding Alicia's role within the PD-SIM Ward Provider Delivered Care Management. I feel like MiHIN and its Thrive initiative may be a shining star upon a hill, like that city upon a hill kind of utopia when we talk about interoperability, social determinants of health, trying to take it almost at the scale it needs to be taken at a community level. I feel like you guys have shown some great leadership in the Great Lakes Bay region, and I think there's more to come, given a lot of, I think, great interest you've had from Michigan Health Endowment Fund, other organizations that really see your community as one that can lead in the space as well. So would you want to share some from perspective from your organization?
Absolutely. I'm Bathro Suteki, CEO for MiHIN, also known as Michigan Health Improvement Alliance. We are a formal 501c3 that was established in 2007, representing 14 counties in mid-central Michigan. The program or initiative that Drew referenced, Thrive, stands for Transforming Health regionally in a vibrant economy, and looking at how solutions to health and well-being can be found locally, and really looking across our ecosystem on where there's key priorities or key levers. One of those key levers that we focused on was social determinants of health, and how it takes multi-sectors and multi-systems to come together to truly address and create conditions for improved health and well-being.
Perfect. Thanks, Beth. So I'm going to ask Dr. Baase to talk a little bit about the national perspective on this work, because I think it's key to both understand where we're here in the state as well as nationally. But I'm curious, any questions so far? I know we're just a few minutes in, but I think important for venues like this where we actually have conversation and have a two-way dialogue. So far you've heard from Katie with State Innovation Model, understanding that test of SIM, trying to understand from a domain perspective how to collect social determinants of health. Alicia's working with payers to understand how you can take that work statewide and work with multiple physician organizations. And then from a more community-based perspective, having businesses come together through this Thrive initiative from a broader community-based perspective. Any questions on those initiatives or other initiatives that you think would be key to share with us in the group, since there's obviously a lot of knowledge in the audience as well for this session? Any questions or comments so far regarding social determinants of health? All right, then we'll keep plugging along, but please grab a microphone if you do have a question, because I do want to make it conversational here with the 20 minutes or so we have left. Dr. Baase, would you want to share, I know you're involved both with Thrive and MiHIN, but also nationally around social determinants of health, some perspective on the work, since I know at least one initiative you've alerted us to that we've been following along is from SIREN, or the Social Interventions Research and Evaluation Network, which is a national group funded, I believe, in part by Robert Wood Johnson Foundation, has attracted an unusually large amount of webinar participants, as I've seen, over at least 300, if you can imagine, on a webinar talking about how to develop common code sets around, I think it's housing, transportation, and food security. So there's a lot of national interest in this work of how to understand and track social determinants of health. So I don't know if you want to add any comments on that particular one or your overall involvement at the national level around social determinants.
Well, I think a couple things would be useful here. So I'm the anomaly on the fireside chat here, so I have a number of national roles, and I thought what would be useful is to just get a quick snapshot of what's happening in this social determinants of health space at the national level and how it might inform us and sort of guide things along. And the context, and just reminding us of the context of why, like why are we even talking about this, what's driving us in this space, and then highlight what I see as the two key challenges and opportunities that are facing this space where we're trying to address social determinants of health right now. So if you're probably aware, because you're getting all kinds of news feeds from many different sources, that there is a lot going on in the social determinants of health space, and there's a lot of attention on that. And in fact, there is even a national organization that's been formed to bring together many organizations in an effort of alignment that's called the National Alliance to Impact Social Determinants of Health, NASDOH.org. And you can go to their website and follow what they're doing. And that energy for pulling that together is really by some insight and understanding of the two major challenges that I'm going to bring. But there is a tremendous amount of activity going on from the National Academy of Sciences and from many different nonprofit organizations, foundations, the federal government, the state governments, other coalitions that are coming together from all different sectors to talk about this. And the why, if we ground ourselves on that, is because we don't have everything operating in our country the way that we would like it in this health space. So we aren't getting the health outcomes that we would like to get. B, our healthcare costs and the healthcare value equation isn't where people are wanting it to be. And along with that, there's a deep realization that the achievement of health outcomes comes from a lot more than just the provision of health care. So there's an imperative for sectors to come together. So I think just not forgetting that, why are we even talking about all this social determinants? And I was sitting in on that last section about all of the electronic decision-making and authorizations and approvals. So why are we having all this dilemma? It's because we're trying to solve a really big, thorny problem about getting healthy people. And there's a lot of pieces associated with that thorny problem. So highlighting those two big issues related to social determinants of health. And I'm trying to help you, Drew. We'll stimulate a lot of questions now.
Be provocative.
So the first thing is that there is a pretty vigorous debate even going on about this, how we're approaching social determinants. And there's a lot of conversation going on about this being in the clinical realm, and how do you screen, as you're talking about, how do you screen individual patients for their social needs, and how do you address them? So you screen them, so then what? And then there's people that are concerned that say, well, it's a necessary but insufficient approach. Social determinants of health are not completely consumed and addressed within the clinical space. That is a broad public health need, and we don't solve all those public health issues just through a clinical lens. So recognize that there's a continuum here, which is how we get into this next thing, which is related to data sharing, which is coordination across community-based organizations. So it's not just what's happening in our primary care offices, although that's important, that we want to look at the development of social determinants of health capacity within the clinical arena, but that alone will not get us to the solution, and we need to have community-based approaches to social determinants that are much broader. So some people will claim that we got to be careful that we don't medicalize the social determinants. So if you hear that argument, there's a dimension there. And
So there's a power dynamic, it sounds like, of who's in charge of this space, and are we all sort of just in a dark room running into each other? Okay.
So keeping that in mind, that there's this broad continuum, there's the clinical side, but there's this very big public health side that we need to coordinate with. And the other is the concern about the flurry of activity and the proliferation of things which aren't coordinated and aligned. So that is a big issue in terms of how do we get to standardization? And if we're not careful, we could easily recreate a problem bigger or the same as we've had with, say, quality measures, where all kinds of different organizations created their own metrics and their own processes around how to measure quality, and then we sort of created a burden for providers around that, and people are pushing back and can't compare apples and oranges, and you got all this issue. We could get in the very same sorts of dilemma around social determinants of health. We got all kinds of people defining it, creating categories and measures for screening purposes. We got other people creating them for community-based purposes, and they aren't necessarily trying to coordinate. So that's what birthed the National Alliance on Social Determinants of Health, and some of that work is saying, let's try to get out in front of some of these. So I'd be happy to talk about any of that in more detail, but I just wanted to highlight the nature of the problems that are also opportunities, because I don't think we're so far down the road that we can't create that alignment effectively and design better from the beginning.
Great. And Dr. Baase, I think your efforts worked. I think we do have a question here.
Name's Linnell James, Blue Cross Blue Shield Association. Wanted to follow up from the national perspective and tie this all back to FHIR and APIs. Siren was mentioned. It used to be called the Coding Collaborative for Social Determinants of Health. It's been rebranded as the Gravity Project. It's following the Argonaut and following Da Vinci. It's taking advantage of what's coming, which is the open APIs that are being pushed by the Notice of Proposed Rulemaking. And we have an actual initiative that includes several payers, several EMR vendors, and a variety of the statewide initiatives, and pulling them all together under FHIR to do exactly what you just said. Let's make sure before this gets out that we put it in a box that's surrounded by FHIR, which the Cerner, Epic, Allscripts, let's make sure we're collecting the data, using some common standards, and make sure the EMR vendors have a place to put it, and the community organizations, some of which that work with NextGen as an example, they're going to be using FHIR. So I just wanted to make sure you're aware those 300 people that came to the call, they came to that call because that's the place where we're going to make sure the standards are aligned to FHIR and what CMS is already planning to do.
That's perfect. Thanks for that perspective. So I don't know if there are any additional questions on that Siren work. I know my understanding is they're working this year on that data set and then moving into how to create that implementation guides for FHIR. So certainly following that work along. Any additional questions on either Siren or anything Dr. Baase or any other our panelists have shared so far? Brianne?
Hi, I'm Brianne with MiHIN. So just a general question. I hear a lot about how with the Siren project we can standardize how we collect information in the clinical setting, and a lot of like understanding that like, oh yeah, this information is really important in the community setting. What's the bridge, and is that bridge bidirectional between community members and providers?
Any good stories you have from SIM, Katie, around that conversation in the community and providers?
I think there's several examples of where there's been interaction between communities and providers, not necessarily just within SIM. There are several community collaboratives across our state that could share examples, but I can only speak to right now the community health innovation regions and providers that have been within the state innovation model, potentially either inside a community health innovation region, or we do have about half of our providers outside as well. There's been significant level of work across the provider organizations and community collaboratives to identify what are priority kind of data sets around social need, and even within that aligned framework that MDHHS developed for the purposes of SIM, how do we take that information on an individualized basis and use it at a population level so that we can drive change in our own community, likely similar to what's happening with Thrive, so that we can align various economic engagements and policies to ensure that we're creating an environment where individuals can thrive and have positive health outcomes and well-being.
I think that that's one critical component, is looking at finding alignment across the sectors. So not just looking at the four walls of the health system, what's happening inside, but looking at public health, looking at universities, looking at the business sector, looking at payers and insurers, and looking at how we can align our business plans and align our objectives so it all is moving forward consistently in a manner that's not duplicative to other work that's already ongoing. And that's something that I think we hear when we talk to our community-based partners, is that their plates are so full, adding one more thing can be that tipping point. Similarly, when we talk to our health system partners, it's the same language, just different barriers. So how do we act or build those bridges as a state?
Mm-hmm. So on the, what's the bridge question? What's the bridge, I think was your question. I think there's several, and I think there are some at the national level. That's what's within the portfolio of actions and the plan from the National Alliance on Social Determinants of Health, is to in fact be that bridge and coordinate that from the full continuum to address both social needs and social determinants at the community level. But when you get to the community level, I would say that bridging activity happens based on recognition, first of all, that there are appropriate actions at the individual level and at the clinical level, and that there are imperatives to do the community-wide organizations, that you cannot get to the outcomes by doing just one or the other, that you really need them both. And so it's, think of the concept of a portfolio approach. And doing a portfolio, if you think, there's probably a lot of people in here that have a stock portfolio, and you're managing that. You have your international, and you have your US, you have your bonds, and you have your short term and small market, large market. You got this blend of things. If we're trying to address health at the community level, it takes a sort of similar thinking about a portfolio. You can't put all of your effort in a clinical side of activity and can't put all of it in the community side. We've really got to look at the entire ecosystem, and by having, that's why there's integrator organizations, backbone organizations at the community level, because they are the bridge. They facilitate bringing the sectors together and all those stakeholders together to create a shared plan and to be looking at the same endpoint targets together, and how each party's going to bring their part to the table to get to, again, keep coming back to why are we doing this? Why are we doing this? We're doing this to get healthier people. And by building the portfolio gets us there.
I have a slightly different perspective as well. So when I think of the bridge between community and the healthcare team, it's extremely local. So as we were trying to build in previous roles that I had, where it was an independent physician organization, where we were trying to build those things, we basically went out into the community ourselves and got business cards and put them in a binder. And either it was electronic or paper, depending on what was the preference. And then our practices used those, and we linked all of the resources up with each of the domains that we got from State Innovation Model, and said, if a person has a need here, connect them here. And we found that it was critical to use something that was so close to our community instead of using some of the major organizations or major vendors that were available, because the vendors that were more available didn't have the up-to-date information that we needed to actually connect a person with what they needed at that moment. And so I think when we're talking about these systems, and I hear the word grassroots a lot, there has to be some way to have up-to-date information of what is happening in the community and of what people are actually using in the community. And so when we talk about things like ADTs and coordinating the care coordinators, something that would be so simple as saying, okay, this community organization saw this person and has an ADT that gets sent back to MiHIN, and that ADT has information that gets connected back on an ACRES file back to the physician organization. Something that connects all of us back so that we're all understanding what the use is one of the first things, so that we can even say, yes, this organization is one of our community partners and our patients are going there and receiving the services that they needed.
And Alicia, that's a great point. So that is one role, I think, with the infrastructure that has been built here in Michigan over the past 10 years, of just that awareness of what services are being accessed. I think that is key. That's one role MiHIN can support in terms of that care team awareness of what services have been accessed by individuals. So that's one role that MiHIN or other organizations may be able to play in that sort of just alerting capacity. So that's one, I guess, focal point of integration, I guess I'll say. But Dr. Baase and Beth, I wanted to circle back with you on lessons you guys might have learned, or maybe even some of the Shire Community Health Innovation Region stories you might have, Katie, around things we're seeing of, is it fun to be a focal point of integration in terms of trying to bring those organizations together, or lessons you guys are learning as you're building that sort of portfolio approach to a very big topic like social determinants of health? Because I imagine probably other organizations here in the audience will be trying to determine what role they can play within their communities. And so maybe as they go back out, things you would advise them to do, maybe not to do, and that might stimulate some other conversation in terms of things individuals in the audience may be seeing in their communities of what roles they could play.
Sure. So I will speak broadly around some of the lessons from community health innovation regions, because I am not the lead on that effort within our state innovation model. But one thing that I will say, and I think it aligns very much with what you already said, Cathy, is that there needs to be kind of bridges at all levels, and there's kind of change that has to occur. So there's individual level change, there's organizational level change, systems level, community level change that has to occur in order to support continued collection of data and using it in a meaningful manner to support moving forward in this atmosphere, and even utilizing it in a way that makes sense for most people. There's a lot of conversation again around Siren, or even the use of LOINC codes or Z codes related to social need, and a lot of that only speaks to one sector in our system here. You know, we can focus primarily on the clinical sector because we have mechanisms that are in place to already support something like collection of data in a manner that is standardized, but then we're not speaking to how the various organizations in our communities connect and share and aggregate this data to make systems level change or environmental change across that community.
Thanks.
I think one of the other challenges at the community level is there's a lot of great things happening, but they're happening at such a small scale or scope or dose that they're not as effective as they could be. And being able to find the community resources to work with those nonprofit organizations or those community-based organizations to be extremely effective. And then also being able to look at how it can be coordinated across the region or across the network to reduce fragmentation. I think those are some challenges or lessons learned, that how do we continue to build a more robust community, and what that looks like from a capacity enhancement.
Great. Any questions? I know we just have a few minutes left that have been maybe generated. See Dan here?
Oh, yeah. So with the state innovation model, thank you. Has there been any, discussion, follow-up about, what was done with the innovation model and how to tie things back to the patient, because the patient is the common thing that links all of these different data areas together. and how that patient can move from different parts of the state and still carry everything that we're learning about them, or that is getting flagged about them, or getting them aligned with different, like you said, resources to help them with those social determinants of health. Because there is a clinical factor, there's a social factor, and then there's that isolation factor too, depending on where you are in the state. I mean, even in the metro areas, people can be isolated just like they are up in the UP. So what has ever been thought about kind of leveraging FHIR to bring things back to that patient, to have a common point?
Sure. So I'm not a technical person that can speak to kind of leveraging FHIR in this way, but our evaluation is ongoing within SIM, and in the entire point across the maturity of the program, to going from where we started with, okay, let's get provider screening so that we know it's happening on a broad scale and doing it in an individualized manner so that it's actionable within that clinical setting, to now let's leverage the systems we have in place across our state to share that information, allows us to evaluate on an individualized level now. So our evaluation is focused on not only what's the process for the data sharing, but also can we take that information that's coming in on an individualized level and use it for understanding what's happening to that individual, apply it across the population as well. So if we see that there's been screenings occurring within a particular physician organization setting and 80% of them are coming back with a housing need, then we can do some population level work. At the same time, that information, it could be tied to that individual. So when they move from, say, Ann Arbor to Gladwin, then that can follow them from the plan that they're working with. They're with a managed care plan to a new managed care plan. It could follow them from physician to physician in an appropriate way. Now that we're very early on in those stages and we're just exploring it, but it's something that we're looking at because it could potentially be the future in our state.
Any other questions before we have maybe a final comment from our panelists? All right, so with just 5 or so minutes left, I'm wondering if we just quickly go around and discuss, since again, social determinants of health, big concept, but it's important to boil it down to what each of our organizations will be doing, sort of immediate next steps, make it more real. I'm wondering if maybe we'll start, Alicia, with you and go back around in terms of, from this conversation, what will be happening this summer within the MICMT, if I got that acronym correct?
Yep.
Around social determinants of health, and we'll do that for the others.
So this summer, what we'll be working with physicians organizations to do is develop the infrastructure for aggregating social determinants of health data. We're trying to build off of, like we said, what SIM is doing, but incentivizing every physician organization, so all 40 of them across the state, to develop some process for gathering the social needs assessment data from each of their practices, bringing it into a central location, and then figuring out how to send it to MiHIN. With the idea being that once MiHIN can collect enough data, and once we can figure out how to then disperse it again back out to whomever needs that data, then we can understand, like Katie said, at a community level, what are the initiatives that we can work on? Is it social isolation that's the problem? Is it transportation? As a community, what are the initiatives that we can work on to support better health in the community?
So I'm going to talk about 3 specific areas very briefly. One area is focusing on protective factors for youth, and through that looking at what screening could exist in variety of settings, and then also building on the adverse childhood experiences, both looking at prevention and addressing trauma-informed communities. And so funded through the Michigan Health Endowment Fund, building a strategy map of what's occurring in our region, almost an environmental scan, and then how we continue to link different organizations to one another to address social drivers of health in that lens.
So across the department, there's the view on how do we look at what's happened within the state innovation model and leverage our lessons from the state innovation model, in particular around the collection and use, aggregation and sharing of social need information. I can't speak to what the answer is and what the next step is, aside from the fact that it's being evaluated and trying to understand if what was implemented within the state innovation model, utilizing an aligned screening methodology, is the route to go moving forward, or if there are some changes that we can make to the system that we created across this demonstration to support continuing this work across our state and with particularly our Medicaid providers and beneficiaries.
Perfect.
Build on that just one quick second.
Build away.
I think it's also important to, from a community level, to understand the challenges of why individuals, organizations are not connecting to the hub and spoke model, and how you can continue to build on that hub and spoke model using enhanced technology for care coordination and looking at the community clinical linkages with that. So looking at what's happening with SIM and continuing to build on the different platforms that already exist.
Absolutely. I think we're going to have some lessons coming from our community health innovation regions and even some of the community partners that haven't necessarily been a part of the SIM demonstration that have utilized the hub and spoke model or have been peripherally engaged in some of this work and following along with the state innovation model along the way, that will hopefully be able to leverage this broader understanding of what's occurred in this field moving forward.
So for those of you who aren't familiar with Thrive, that was mentioned here, that's a very big, bold, trailblazing sort of effort that's happening in this central Michigan area through the efforts of MiHIN and the Great Lakes Bay Alliance. But that initiative does have a big portfolio, and we're in phase 1 of 4 phases. In that phase 1, we're addressing some of the things that Beth has mentioned here. One of the phase 1 initiatives is enhancing technology applications to solve our biggest challenges, so that'll be coming into play. I'm just trying to link it to the work that MiHIN is doing. Flipping back to the national level, currently active in the National Alliance to Impact Social Determinants of Health, NASDO. They have just finished doing complete mapping at the federal policy level of all the current activities and initiatives that are set to impact social determinants of health. Currently, they've got 16 federal departments, each have one or more initiatives on social determinants of health. There's 25 different social determinants of health federal policy initiatives underway. Those are listed in a table that's been created, and it's by Levitt Partners. It's on their website, so it's a publicly available document. I can give it to Drew. You can get it out, I guess. So that document is available in either PowerPoint or Word, so you can keep track of where the field is moving at the national level. The second thing is the NASDO organization has just finished documenting whatever they can find, and it just keeps growing in terms of national level activities. So NCQA, who's developing measures for social determinants of health for PCMH practices, and NCQA, who's doing social determinants of health measures for health data integration. And we have NQF has an effort with Aetna to do social determinants of health. 100 Million Healthier Lives has an effort. Medicaid's formulating recommended measures for this. That's siren work that we mentioned. Healthy People 2030 has community health indicators related to social determinants of health. And this goes on. So they're really trying to drive that, and one of their courses of recommended action is to say, let's get this aligned at the beginning, and they've got an outlined process for that and have set a set of guiding principles. So the The foundation of that alignment, they're hoping, will come from a set of guiding principles that people that are working in this area will understand and sort of align to. So there's 10 of those guiding principles, and I won't bother reading them to you, but they're available on the website. And there are some specific framework suggestions and a call to action around that.
Thanks, Dr. Baase, and all of our panelists. We are at time, so please join me in thanking our panel.